It's my pleasure to introduce one of the well-known dear colleagues, Dr. Hadi Abu Hantash, with the second talk, Lesson Learned from the Jordanian Heart Failure Registry. I'm sure we will listen for good data and from a great speaker.
Welcome to Jordan, all of you. Being the governor of the American College of Cardiology chapter, it's my honor to get the distinguished chapter from the ACC 3 years consecutively, 21, 22, and 23. We embarked on the Jordan Heart Failure Registry 3 years ago because of the lack of data on heart failure in Jordan. The whole purpose of the registry was relatively simple. We wanted to obtain reliable data on demographic and clinical data on heart failure patients in Jordan. It's an observational cohort prospective study. We aimed at enrolling more than 2,000 participants. We were hoping for 12 months. We were at the end of the COVID era at the time, so it was not an easy job, but we finally got there. We registered it with the clinicaltrial.government, the NIH US National Library of Medicine in April 21. The study is relatively simple. Anybody with heart failure above 18 years old is a candidate as long as they can sign the consent form, and we make sure that we can follow them up. We were honored to have principal investigators, most of them are amongst us today, from 2 university hospitals, 2 public hospitals, 4 private teaching hospitals, and 10 private non-teaching hospitals. Thank you all. Without your support, nothing could have been achieved. We followed for consistency the guidelines from the European Society of Cardiology in 21 in terms of definition of heart failure with reduced ejection fraction, medium range ejection fraction, and preserved ejection fraction. We also encouraged all our PIs to stick to the diagnostic algorithm put forward by the European Society. We were hoping that documentation of basic labs, including biomarkers, 12 ECG, 12 lead ECG, echo, chest X-ray, routine blood tests, including iron status, to be in the charts. So let me flip to the results. We managed to recruit 2,151 patients. And to make it rather a unique registry, we looked at both acute and chronic heart failure. We found that amongst the participants, almost 30% of the patients presented with acute heart failure and 70% with the chronic. How did the echo variables in terms of ejection fraction of the whole population ended up? We had heart failure with a preserved ejection fraction of 30%. If you define the HFpEF as EF above 50, so 30% of our patients were heart failure with a preserved, 70 with reduced ejection fraction. But if you look at the various ejection fraction variables, what do we find? It's interesting here, and I think we'll look at that as subgroup analyses. The intermediate ejection fraction patients, range ejection fraction, were 35%. That's quite intriguing to me because that's something to be looked upon. Mitral regurg. Mitral regurg by echo was reported in almost 1 out of 4 of the patients who were enrolled. Mild, moderate, and severe, but you can see that moderate was about 40% and severe 7%. That has an implication because we know sometimes for those patients at the end stage resistant to treatment, we use MitraClip for them. How about representation of females and males in the study? I'm glad to tell you that in Jordan, I don't know how that happened, don't ask me, 42% of the patients enrolled were females versus 58 who are males. The mean age was consistent with most of the trials done across the globe. It's just about 66 years old in both acute and chronic heart failure. And we all know that heart failure is a disease Well, it's not, we see young patients, but it's the disease of the more older patients. So you can tell that when you are above, when patients above 60 represented almost 72% of the patients. What about previous history of heart failure? How many of those patients we enrolled actually were naive patients, the first time presenting with heart failure? 81% of the patients had history of heart failure in the past. So we're talking about naive patients, hardly 20% who were enrolled. Now, what you see here, that history of arrhythmias, 1/3 of the patients, implanted devices expected, that is very low number. History of structural heart disease, also low at 6%. Something which I'm actually very intrigued with, that we in Jordan, we do biomarkers a lot higher than a lot of our surrounding countries. And this is open for discussion and questions from you. We reported BNP in almost 33% of the patients enrolled, pro-BNP 15%. Believe me, that's impressive. And I'll show you why. Now, we know that the sensitivity and the specificity of both biomarkers is quite high, above 90%, which is wonderful. But if you compare it to the Gulf Care Registry, less than 25% of the patients who were actually enrolled had biomarkers in the chart. So we're not bad at all. And when you look at the European Atlas epidemiological data published in 2019, you look at the bottom there, hospitals which were offering BNP were 1.13 per 100,000 inhabitants around. With the highest, of course, you can tell, it's Germany, of course. But I think comparable, what we're doing is not bad at all. So how sick were our patients who were enrolled in the study? When we look at the number of hospitalization of heart failure in the past 6 months before enrollment, you look at that, what do you find? You find that almost 40% of those patients had previous hospitalization with heart failure. So they're actually relatively sick patients. What was the etiology? Consistent across the globe. It's ischemia. Ischemic cardiomyopathy was dominant in about 60% of the patients, followed by hypertensive cardiomyopathy. To my surprise, I don't know how to explain that, valvular and structural were a bit underrepresented, while idiopathic was 17% in both acute and chronic heart failure. What were the atherosclerotic cardiovascular disease risk factors involved in our patients? Diabetes. I can't believe that. I mean, I was expecting 40, 50, 69%. We beat even Saudi Arabia in that, my friend. I mean, that's really too much to handle. 69%. I mean, that's really a lot. And as the other comorbidities in the other global studies showed, hypertensive as a comorbidity patients, 80%, dyslipidemia, 58%, obesity, 36%, 36% obese patients. How about previous atherosclerotic cardiovascular disease history, like previous MI, cabbage, carotid disease, peripheral disease, etc.? It was present in almost 80% of the patients, 80% of the patients. Something intriguing. We wanted to see how good we are of followers for guideline therapy. We looked at the medications at the hospital admission in acute heart failure or the first office visit in a chronic heart failure. What do you find? SGLT2 inhibitors, 8.8% of the patients. Not bad, considering that we started in 21. But look what is the most popular medicine in heart failure patients in Jordan. Beta blockers. Beta blockers is being loved in Jordan for heart failure patients, followed by RAS inhibition. RAS inhibition was used in about 1 out of 2 of our patients, and if we look at aldosterone antagonist, was 1 out of 5. If we look at the 4 pillars of heart failure treatment as identified by the various guidelines, you put them together as an aldosterone antagonist, ARNI, beta blocker, SGLT2 inhibitor. I'm sorry to tell you, my friends, we're not doing good with that part. We're very low. If you put the 4 pillars together. However, if you put the ARNI out, you put ACE or ARB, for somebody who would say it's the money which is making people not putting Entresto as a prescription. Well, I'm sorry to tell you, it's not. It's just simply, we are not sticking to the 4-pillar type of recommendation. The most popular, again, combined RAS inhibition and beta blocker was used in a total of 40% of the patients. Patients who come in, whether during heart failure hospitalization or chronic heart failure first office visit, as usual, 1 out of 2 were on loop diuretics. A lot less were nitrates, DIGs, thiazide diuretics, calcium blockers. Of course, it reflects because we have almost 80% of the patients who are hypertensive, which makes sense. Symptoms. The salient symptomatology of heart failure, we know, it's dyspnea. So, like what it is in our textbooks. So dyspnea was a predominant, about 85% of the patients, both acute and chronic heart failure patients, followed by, you look at that, which is really interesting, orthopnea and PND was also there, and almost one out of 3 patients, depending on which acute or chronic heart failure you look at. In terms of a New York Heart Association class, we see that it was variable, looking at stage 1, class 1 of 14%, class 2 30, class 3 30, and at rest 4 at 11. So we had, when you look at this, it tells you that we have sick patients in our hands. We have 40% of the patients who are actually in stage 3 or stage 4. This is an important slide to look at. Why is it important? Now, when we look at the heart failure patients admitted to the hospital or at your office visit, the initial, not a lot of them had a blood pressure as a hypertensive type of patients above 140/90. That's very good. Why? Indirectly, it tells you 80% of the patients who were enrolled with hypertensive, we're doing good controlling them, which is wonderful. However, this slide is very important, take-home message, that the patients who were actually in cardiogenic shock were little, 4.2 in acute, 3.45 in chronic, but you look at the patient's dominance, about 101 to 140, 66%. What's the message here? My friends, the message is go by guidelines. If you believe this slide, if it's real, 66 of your patients, percent of them sitting in front of you, they are candidates for the 4 pillars of medicine from the first visit which you see them. This is the message here. Don't start one by one. There is no need to do that. Sodium is important. Patients who were hyponatremic were low, which is wonderful. 6.3 in acute, 5.4 in chronic heart failure. Potassium, we know that it's a hindrance to have a hyperkalemic patients in your hand because you cannot play around with RAS inhibition. But here we have good news that most of our patients, 80% of them were between 3.5 and 5 as a potassium level. Important slide. Patients who were anemic, total were 16%. We underreported, for whatever reason, the ferritin level in those patients. We had hardly 62%, 62 patients who were reported. 27 actually had anemia, and the rest, which were 35, had no anemia. Why am I pointing this out? Because we have to encourage our colleagues to have an iron study, namely ferritin in those patients, and if not, put a transferrin saturation, because we all know that IV treatment with iron can improve their New York Heart Association class. To our surprise, eGFR, low GFR was there. People who were less than 60 mil per minute, when you look at that, were 42% of the enrollees. So watch out, because that's a hindrance also for prescribing RAS inhibition, etc. EKG, normal EKG was in 1 out of 5 AFib, about 12%. Patients candidates for CRTD, left bundle and right bundle, were just about 12%. So what did we add during the hospital medications before discharge, acute or chronic? Again, beta blockers were the dominant, 42%. ARB was, ARNI was added at 7.5, ARB 10%, ACE at 10%. Now, the discharge medications, I won't go through that, but I think we're doing fine in a way because we are focusing on RAS inhibition plus beta blockers. Give me just a couple of minutes or less, please. Procedures for acute heart failure, during acute heart failure, hospitalization, 68% of the patients had no procedures at all. Cardiac cath, 1 out of 4 of our patients, PCI 4.3. Now, parenteral therapy, you can imagine, the most common IV treatment uses Lasix. We used boluses in 70%. We used infusion 20%. When we look at the hospital stay in acute heart failure, our mean hospital day admission was 6.2. When we look at the European Society of Cardiology, it was 8.5. I don't know if you want to take a home message that we are putting them less in the hospital, but that's what we got. What was the primary cause of death for patients which were reported with that? It was cardiovascular, when you look at that. In the acute heart failure, 9% mortality cardiovascular, in the chronic 6.4. Relatively consistent across the board, by the way. This is a slide which is the take-home message. When we look at the other studies, registries, regionally in Europe and in the United States, we put Jordan here on the right, acute and the chronic. The number of patients we had was more than 2,000, which is reasonable when you look at Egypt, which is, I have wonderful friends here amongst of you, they hardly recruited 2,000 in the registry, so we're doing not bad at all. The mean age was consistent, females, we presented them more, diabetics, unfortunately we had a big number, but you look at the United States also, they had the same issue with diabetes and hypertension. And the patients with HFpEF, which we enrolled, as defined by this slide, above 40%, including the intermediate range, we had 52% of the patients with HFpEF in the acute heart failure and 51%. I will not go through that, all of this. Now, what are our future plans? This is my last slide. Jordan was approached, and I am honored to tell you that, by the European Society of Cardiology Heart Failure Observe study, main investigator, to be part of the Observe registry, which was previously known as the Heart Failure Atlas, and hopefully we will be part of it. I'm looking to create the Jordan Cardiac Society Working Group on Heart Failure, because I think that's essential to have under the umbrella of our Jordan Cardiac Society. The ACC Middle East Conference, which is coming up in Athens in autumn. We are working very hard with the ACC in Washington, D.C., and I'm glad to tell you we had a 50% chance of getting it in 2025 in Amman, Jordan. But I can tell you it's almost 100% that they are coming to us in 2026. Thank you very much for your attention.